for the removing the systematic bias or systematic error. So we follow the all sets of the rule. See here, if we take the this is a smaller sample size, so definitely it have the some amount of the higher random value, and we taking the higher sample size. So in the mean average for both in the cases almost same. So in the random error doesn't affect the average or the mean, but the systematic error, here they are significantly different. The means are significantly different. So then the random error is classified into two categories. All are, I think, so aware who have done the thesis. That is the type 1 error and type 2 error. Type 1 error is known as alpha error and type 2 error is known as beta error. So type 1 error is the false positive study. False positive here means null hypothesis is true, but we are accepting the alternate hypothesis. Means, see in this diagram, this is the male, and the test showing it is pregnancy test is positive. So, as per the null hypothesis, it should not be, but it is showing. So, it is the false positive result. So, it is the type 1 error. And we keep the type 1 error is the 0.5%, or on the basis we measure the p value. Second is the type 2 error. Type 2 error is the false negative. Means here we in this diagram we see the pregnant female test showing negative. It is a false negative result. And this type 2 error especially for utilized for the power of study. You have known the beta error and power of study, and we are keeping the value of the beta error is 0.2, and the reverse of this is the power of study 80% usual, but we may increase 90 or 95, but the sample size will increase. Then how to minimize the random error? So one of the best method, you increase the sample size first. So the gold standard of the area study, the RCT, where all confounding factor, all selection bias is removed, so then the chances of random error is very less. Second, we should calculate the power and the aggregate sample size for any study based, and that is the sample size is calculated based on the mean, that is the clinical significant difference, or we expected how much difference we try to observe. So on that basis, we design the sample size. So sample size usually calculated from the either previous study. If the previous study is not there, we use the pilot study. Then the sample size must be reasonable, and also it is acceptable to the other peer groups. Another thing, we should, for reducing the random error, we analyze data with the appropriate test. So while making the hypothesis, at that time you design your test. It may be parametric and non-parametric, and but basis of the test we design according to the normality and homogeneity, but should be defined earlier. Now to come to the systematic bias. The systematic bias or systematic error can take place for any part of the study, and it may be environmental or instrumental or observational or theoretical. Here you can see, we found person is taking the reading, but he or she forget to make 0, 0. Before taking any measurement, you make the instrument at the 0, 0, at the 0 level. So still it is 2, so is showing. So whatever the repeated measurement we will take, it is 2 is added every time. So that type of the error is introduced, that is known as one type of the systematic bias or systematic. Second important point, we are taking the radiation in this room, the radiation counter. But at the same time, there are so many mobiles in our pockets or in the bags. So their radiation is also counted. That introduced the systematic bias. Third one, observational. Liquid in the cylindrical tube. We try to see the level. At the same level the liquid is there. Not from above, not from the below. If we see from the above, it is underestimated, or if it is showing from the below, it is overestimated. Reading will be great. Third, last one is the theoretical. So theoretical is the when we take the assuming, means our weight is doesn't take change from the no difference between the morning and evening. Our body temperature it doesn't vary in the morning and evening. So that type of assumption sometimes also introduce the error. This type assumption is known as theoretical systematic error. So the systematic error can be any place part of the research, from starting from the literature review to the up to the publication. How the publication can introduce the error? Because always the journals want to publish the positive result. Journal doesn't want to publish the negative result. There is no result, they doesn't want to the publish, but it is a bias at the level of publisher or the level of reviewer at the level of editor. So now how to reduce it? So the systematic bias usually mainly 2 or 3 types. One is the selection bias, means sample on where we are doing the study doesn't truly represent the population. So here there is a population and we selectively remove the red color person. There is a one group of the person. So definitely their baseline characteristic different from the population. So when you are review the any paper and you find that the RCT randomization is done, if you want to know the whether properly randomization is done or not, you check the age, weight, height it is mentioned as the baseline characteristic, and there should be non-significant difference between the two groups, between the case and control. If it's any level, if there is a difference, definitely there is an error in the random sampling. Or if the person doesn't do the random sampling, then he or she must say it is consecutive sampling or what type of non-random sampling they are using. That is. Second important factor is coming the confounding factor. So when the risk associated study is done, there is 2 or more risks are associated, like that cancer is studied with the person having the alcohol, using alcohol, and at the same time smokers also have the cancer. So in the population, 25% are non-smoker and alcoholic, and rest 75% is smoker as well as alcoholic. So when we are taking the sample, we should keep the same ratio. If it doesn't keep, again will lead to the selection bias. Then the information bias or misclassification bias. What happened? We are unable to classify the disease person, non-disease person, or exposed and non-exposed person in the required study or case control study. So in that case, they also introduce recall bias, means patient doesn't recall about that using the drugs during the pregnancy when you are studying the congenital disorder. So that type of the lead to the recall bias. Observer sometimes have the clue about the participants. Then again they can introduce. Similarly, detection bias. It also due to the at the time of the that's why we are doing the blinding and allocation concealment in case of RCT. To keep the investigator should not know the case and control, and they are appropriately classified on the basis of inclusion and exclusion criteria. There should not be any mix. Such type of the criteria we can mix the both case and control. So these are the process of to reduce the systematic error in the systematic bias. We should randomize blinding of the subject, but for the anatomy you should blind the observer and person doing the data analysis. Intention to treat the analysis usually we don't have because it is more about the clinical side, and the blinding of the assessors only along with that. So second part is the most important, or where we anatomists doing the mistakes, or it is done by all of the people, but we are also doing the mistake. That is the measurement error, or we can say the blunder. If we see when we are taking the blood sugar of your own, we visit to a new lab. So you are always want to query whether that result is true or not. You are always curious about that. So how that we know? So similarly, when we are doing any study, the methodology part is just like a tool or just like an instrument. It has the certain value in the form of sensitivity, specificity, reproducibility, there is an agreement between the investigators. So these parameters are important while we are doing the study. First of all, we are discussing the reproducibility. What is the reproducibility? The observation made by the two-rater. Normally, what we do in anatomists when we see the paper, we observe a study done by the single observer, not so definitely introduce the bias. My finding may not be he is say that it's right. He may differ. So the reproducibility is that observation made by the two raters in the same subject in the different environment should be correlated and should have the correlation more than 0.8. Should have the correlation about more than 0.8. But up to 0.6 it is acceptable. Like that, agreement. When we are classifying any bone or any muscle, there should be agreement between the two people. It is not that it is one person is telling it is the type 1, another one says no, it is type 2. So there should be the agreement. So for this we should collect the data and try to take the kappa statistics to know especially when we are taking the categorical variable, when we are not measuring anything. So in that case, we should take the kappa. If we are taking the length or measurement, we should go for the level of agreement, that is the blank argument plot. Then repeatability. Repeatability, in some part you have already encountered. I think most of you have done the questionnaire based study. So you are making the sets of the question to a study. So that question should be test and retest before it is implemented. Means every time is it giving the same result? Just like the balance, if it doesn't give the same result at the same every time, then you do not understand that you are not going to use that tool. So any tool must give same measurement every time. There will be the random error in the final, but approximate value is there, must be similar. Then the reliability. So reliability, we are checking, we do the repeated measure and we see the variations between. So for this we are doing for the minimal detectable change and coefficient of variation. So here I am trying to just give you some example here. If you see here the rater 1 and rater 2 computing the left ventricular ejection fraction, and this is the line of equality. So when we are plotting the value of operator 1 and 2, the line should align with the line of equality. Then it is called well correlated, or you can say the study has the reproducible. It will have the coefficient. See here, it is 0.82 for regression is more than 0.9, and the bias, you see there is a very minimum bias. So similarly here you see in that case the line it doesn't fall in this category at the line of equality. So definitely it is have the bias. Means operator 1 significantly given the lower value as compared to the operator 2. So these are the example of the bias. These are rather known as professional bias, little bit difficult for understand for everyone. So that's why I'm leaving. Here you see that this curve. This curve is known as bland argument curve. What here we do, we take the two raters, give the value, we taking the mean of that and difference of that, and then we are plotting. And then we see these are the zero line that is the agreement should be at the mean difference or bias should be at the level of 0. In minus 0.0056 it is acceptable, there is no issue, but it should be near about 0. And all dots of observation should be between the upper line of the agreement and lower line of agreement. Any dots beyond at least 3 dots, it is acceptable. Beyond 3 dots, above or below the line of agreement, it is shows there is a significant disagreement between the raters. This is the having the agreement, but there is confidence interval is wider. And these things are assignability. It is difficult to do. If you see here is there one master chart, just simulated data. There are 6 samples in there. Here the operator 1 taking the 3 reading. Operator 1, 1, 1, 2 take the 3 reading. And we take the mean of the operator 1 and SD of the operator 1. Then similarly we take the operator 2 also take the mean value, 3 readings and the mean of that and standard deviation. Now we take the correlation coefficient of mean of operator 1 and mean of operator 2 and you will find that 0.99. So this is a strongly correlated. We follow also the regression, means these all 3 readings are well related to this value of the operator 2. We do the regression coefficient and again value is almost 0.99. So there is a significant significantly reproducible, you can say. Then we take it is the mean of the rater 1, this is the mean of rater 2. So we take the mean of that. And there is a difference between rater 1 and rater 2 is taken as a bias and then we are plotting it. So you see there is a line of, these are the upper level of line of agreement, this is the lower level. Here the center line is not visible but it is at the level of 0. And see the all readings are between the two agreements. So this is the plotting analysis. All things can be done in the Excel. Another need to do in any other software. So here we are taking the another thing for the reproducibility, the intra-class coefficient. So it is a little bit tricky, I know, but still it can be calculated for the rater. This is the compass statistic. Here you see the both of the rater have a very good agreement for the each level of classification, non, mild, moderate, severe. But here the agreement is poor. So repeatability, when you take the measurement of the repeated time, the mean value must be follow the almost a linear course. If it is haphazardly present, there is no repeatability. Or if there is a bias, every time we will get the higher value or lower value like this. So that is the significant, it will help you to identify the bias. So now come to the evidence, the main part, that is the evidence-based anatomy. So if our body have the at least 10 to 20 variation in every category we will get. And some, not all variations are important, but some of the variations are clinically important. Just I have given as the example, that is the bifid. Median nerve is bifid, and that is one of the association lead to the carpal tunnel syndrome. Or interthalamic adhesion is absent, usually present in the most of the cases. But if it is absent, it may lead to the neuropsychiatric disorder if there is a in such environment they face. So anatomical knowledge and the surgical skill both contribute to get the best anatomical and clinical evidence, and that will give you best clinical outcome, avoid the surgical error as well as malpractice claim. That's why the concept of evidence-based came. So, how the systematic review and the traditional review is different. The systematic review is main difference in the risk of bias. What we are discussing is the systematic bias or systematic error. In the systematic review, we are taking care of that bias. So for this, we are initially planned for inclusion exclusion criteria after the research question. We also planned what are the keywords will be used. There is no control of the any author on this. Whatever the initial part of the project is written, it should be followed. Because usually it is done in the tools, so here all the things are in advance we have to enter. Then we can start. So for the formulation of the research question, just similar to the original article, we can follow the PICO model or a spider or the spice. So PICO model is not always related to the anatomy, but we examine the spider model like any variation you see as a phenomenon of interest. A spice model usually for the medical education. So first of all, we should make the protocol and we are trying to register it. We have to follow the PRISMA guideline, and registration usually done to the multiple sites are there. Cochrane collaboration or Campbell collaboration, Prospero, JPI, Johanna Drake Institute, Open Scientific Network, where we are doing the. But I usually prefer the Prospero, it is more easier to get. Then, first of all, we take the inclusion and exclusion criteria, we define. Then, at the same time, we also, from the research question and title, we take the keywords in the PICO format. What are the participants, what are the intervention or exposure, what are the control, what are the outcome. Now, then we search the base term in related to that. We go side of the format, you get the mesh term, that is the medical subject heading. Then we follow the terms related to anatomy because it is related to terminological anatomical Latin words. Sometimes we have to use the synonyms also. And there is another like that mesh term, that is the M3, that is related to the MBAS database, in-base database. So we are also using the keywords. Then with the keywords and the Boolean operator, these are the Boolean operators, or and not, we create the such string, and then such strings are combined together make the such start. Then what is the database? We should take the Medline, Scopus, Web Science, Web of Science, MBase, CINHL, Google Scholar, Cochrane. But for information, at least 3 major databases must be searched. Minimum 3 major databases. So I prefer to use Medline and Web of Science and Google Scholar. Then we need because the so many citations are when we are doing the search that there thousands or hundreds of the citations are coming. So we need the reference manager, that is the EndNote or Getoro. Then we transfer all the this to the these 3 portal. Any of these can use. They are Rayan AI, Pico portal, and Providence. Last 2 are paid, so you need the subscription. Then like that, this is the PRISMA guideline with all 3 databases are searched. Initially, we remove the duplicates, then go for abstract screening, full text screening, then lastly, whatever the article is left, it will go for systematic review, or if it is data permit, go for the meta-analysis. We also include unpublished data because the principle of the systematic review are based that no article should be left because a negative study definitely have a negative estimate which alter the final effect size. So if you are adding only the positive result, definitely it will give you the positive result. So for the removing the bias, we should add both positive result as well as negative result. Here we use, I have used the Rayan AI software. All reference are collected and it is transferred here. Now you see the one button is there, detect duplicate. So yes, they shortlist all of the reference, it is duplicated and removed. Then here you see, initially we do the abstract screening. So first we are reading the abstract. If it is suitable for my research question, I will include. Otherwise, we exclude. But when we exclude, always we should give the reason. Or if it is indeterminate this time, then you use maybe. But whatever you give, you will do it is shown in your list. Like that, we have done the initially 344 citations are transferred there, out of which we have included 95, excluded 90. There 159 are duplicates. This is all data are coming. Then we do the out of 95, we again do the full text review. Means all of the manuscript we have read, and again we see the research question and we follow that. Then we have excluded 75, only 20 is left. How much time it will take, it is also mentioned. So next part is the data abstraction. So these are the software, it is paid, so I'm not using, I usually prefer the Google Sheet or Excel. We take the all baseline characteristic, primary, secondary outcome. Here, that data is also showing. Here you can appreciate author year, population, what are the events, what are the sample size, what are the prevalence. Then we calculate both lower confidence interval and higher confidence interval, and also assign the weight of the study based on the variance. Now, the most important part or heart of the any systematic review is the risk of bias assessment. So, for what we anatomists, we need this one. Because most of our design is the cross-sectional study. We are very rarely using the RCT. Only especially we use in the case of the medical education or anatomy education. So here, these are the factors the same what we are discussing earlier. That reproducibility, that part comparison and outcome, we should go for that statistics part. Then almost 80-84 tools, but very frequently used are Robbins 1, Robbins 2, that are the Cochrane tools. Jared score, Newcastle Ottawa score. I usually mostly use the Newcastle Ottawa score, is very easy to use, and along with the anatomy quality assurance tool or assessment tool. These are the anatomy quality assessment tool, Aqua tool. It has the five domains. That is especially related to the objective, study design, methodology, descriptive anatomy, and how you are reporting the result. And you always give your opinion. There is a bias is present or not, yes, no, or it is unclear. For all domains you have to give. Here I have given for all domains. Now, if the data is suitable, what is the exposure data or outcome data, then we go for the meta-analysis. If it is not, then only we make the evidence synthesis stable, and that much is the systematic review we end. And we synthesize our final evidence on that basis. So, for the meta-analysis, there is some prerequisite is there. Meta-analysis is not performed if the data is qualitative, or if the data is quantitative but very high unexplained heterogeneity, or variance of the studies are having the outlier category. The software you can use Revman, CMA, MetaExcel, MetaEssential, whatever you can use. It can be done Excel and Google Sheet also, but little bit tedious job. So always in the meta-analysis, the one term is always you heard, that is the effect size. What is effect size? Most of the people are usually clueless. So effect size is that always we are giving the p-value. So this result of this, having the result of this significantly higher or significantly lower. Suppose the mean blood pressure, this one group, and mean blood pressure of the second group, significantly higher. But the magnitude of the higher or lower actually effect size. Means if it is the 100 mmHg, another is the 150, so the difference is 50. That is known as mean difference. So that difference is the effect size. So that is true for the two samples. When the sample are two, but when there is a single sample, the mean weight of this room is the effect size. Mean weight of this all people in this room is again effect size. It is the concept. So for the one sample, prevalence, mean, correlation, odd ratio, all are effect size. For the two sample, odd ratio, risk difference, mean difference, standardized mean difference, they are the effect size. Even the specificity, sensitivity we are measuring for the any test, all are effect size. So for the computing the steps of the meta-analysis, we compute the effect size, we allocate the weight, assess the heterogeneity, then we calculate the mean pool weighted effect size. Then if we try to observe the heterogeneity, if it is less than 50%, we follow the fixed effect model. If it is heterogeneity more than 50%, we should follow the random effect model. I will say later on, and then we make the forest plot and also the funnel plot for the publication bias. This is a fixed effect model. In fixed effect model, what we consider, there is zero difference between all of the study. Means the study from the almost similar population having the similar values. So in that case, we use that formula for the final effect. And this one is the here Cochrane Q we are using for the heterogeneity, for taking the heterogeneity. So if the heterogeneity comes less than 50%, we use this formula. If it is more than 50%, we have to adjust, because in more than 50%, definitely there is a variance coming from the study between the study. So that variance are also added here, and then in that case we calculate using this formula. So here you can this is done in the Excel. We calculate author year, event, sample size, outcome, standard variance, weight, allocate according to the variance, we allocate the weight. Then all this procedure done, and we complete the effect size for the fixed effect. For the random effect, again we are doing that part similarly. So robustness of the meta-analysis depends upon the two important factors. One is the heterogeneity statistics, another is the publication one. Heterogeneity statistics, that is we normally heterogeneity measured by the Cochrane Q, Higgins I-square statistics, tau square, that is gives the variance, and tau, that is the standard error. So to deal with the heterogeneity, we try to do initially subgroup analysis. We do the try to do the meta regression based on the baseline of the characteristics. Then sensitivity analysis, cumulative analysis, and if or it is still heterogeneity is not completely explained, and we have to get the effect size. We have to finalize for the effect size based on the heterogeneity. For this, we are doing the separate analysis that is known as trial sequence analysis. So for the publication bias, there are so many, but most commonly use the funnel plot. So here is the forest plot. So first we should know how to read the forest plot. Forest plot has just like x and y x-axis, we have the reading. One favor the control, another is the intervention. You may change it. This dark line is showing that is the no line of no effect. A line of no effect depends value below the value, either maybe 0 or 1. When there is a 0, then we are seeing the difference. And when there is a ratio we are observing, definitely it will be the 1. Here differences are visualizing. That's why here I am seeing the ratio, odd ratio. So if there is no difference between the two groups, definitely their ratio is 1. But when we are seeing the difference, if there is no difference, mean effect line will be at the 0. So you can see here, these are the forest plot. This line, blue line here, or this line is showing the confidence interval of each study. And in between there is a square shape. It is showing the weight of the each study. And after combining, this is the diamond shape. This is the pooled effect site. Pooled effect site, and its end define the its confidence interval. So here we have done the subgroup. This is called subgroup analysis. We divide the risk in the two groups: normal risk and carpal tunnel syndrome. Risk having the carpal tunnel syndrome. Again, we have did these are the forest plot. Then publication bias. Here you plot the standard error of the odd ratio and the effect size. And all studies should be fall within this triangle. If it is beyond this, or if it is not each level is present, then there is a chance of publication bias. After doing this all, we write the manuscript, and when we write the manuscript, we follow the Prisma checklist. Or it is 2 pages, and it is not working. So this is the almost last slide. So all of the every report and their page number of the manuscript should be written here, and they have to follow the same. What are the things are asked? We have to write. It is given in the Cochrane tool, that is the REPEN. It is given what you have to write. So why the criticism of the systematic review and meta-analysis comes? The one of the most important is the garbage in and garbage out. Means if we take the poorest study, definitely the effect size what we computed will be poor. If we take good quality of the study, definitely our effect size is good. That is a major drawback. And this is the reason sometimes a large sample size RCT is considered, it is better than the meta-analysis because of the presence of the heterogeneity. Because when you are combining the study, their variance are down, and that lead to the heterogeneity. So this is all about for my presentation. If you have any query, here you may ask, or even after this, you may ask on the WhatsApp. I am every time available to answer your question.
Thank you for your presentation. That is throwing light on the inner part of the research. Sir, it been a short time, but sir has explained the detail, that is the bias statistics, starting from that is the error from the bias. Random error and the systematic error, and how to do a meta-analysis. It's almost all the entire part of that bias statistics, including the Boolean factor and publication bias and everything. Very good, sir. Excellent, sir. That is nowadays that we need for those who are doing that research, and especially for the PhD scholars and such a thing. That is the wonderful talk, sir. That is If it will be, I think that it will be good for sharing that such a thing to.
Sure, I
the
understand
slide
that.
and the screenshot or something. If you are sharing, it will be reliable. It is very good.
Okay.
I was touching each and everything about that, the validity, the reliability of the test, everything, sir. That is just I felt that is just recollecting my that statistics study is what we are studying. That is in a short time. Sir. Thank you, sir. Thank you, Rakesh. The topic is open for discussion. If there is any queries, that is.
Thank you, Dr. Arun, for giving every intricacies regarding the meta-analysis. My only question to you is, how much time is required just from conceptualizing a particular topic and then completing a meta-analysis?
Time vary from the, at minimum time, it depends upon your research topic, and at least it will take your 6 months your time, and it may take up to 3 years or even 5 years. It depends upon the intricacies. So for anatomical meta-analysis, I am 100% sure if you are using the tools that can be finished within the 6 months. Even faster than your research project. Because if you are applying for ethics approval, it will take 6 months. So by the time you are taking the ethics approval, one of the study you are complete. Thank you.
Good morning all. I would like to suggest to senior Dr. Adil, Dr. Bua and other senior faculties that if a training sort of some structure is kept within this year, so that whoever junior teachers or the postgraduates want to attend it, because one presentation in a conference I think is not sufficient enough for people to get imbibe it. So अगर ये हो जाता है तो बहुत अच्छा रहेगा, right? Is it?
Sure.
Is it? Am I right?
Yes.
Okay.
So any question? I'm happy to answer. Okay, when you feel there is something, you definitely give the WhatsApp message on the WhatsApp and definitely answer.
Thank you, sir, for the enlightening session. So I just like to call to validate it, sir, for the excellent talk. I would also like to request Dr. Smita to felicitate Dr. Sandhu and Dr. Mugathan who are the chairpersons for this session. Thank you. So for the next session, we have Dr. Joseph, who will be speaking on the use of anatomy and imaging and implementation and anesthesia. For chairing the session, I would like to request Dr. S.K. Burman and Dr. Mohan Bak to please take the chair.
Angelo, settle down and go start. Yes, sir. Please settle down.
with CT scans. Under CT guidance, we do a lot of our procedures. MRI and PET don't have much of a role per se in anesthesia, but yes, we use these imaging modalities as adjuncts to our practice.
Now, please, sorry to.
Please, okay.
Yeah, so we have come a long way in the imaging modalities. William Röntgen in the 1800s discovered X-rays quite serendipitously. Then in 1970s, CT was found, MRI was found. Much earlier than that, ultrasound was in use. But all these came to India a bit late, partly because these were invented in the West, the cost and the difficulty in implementation. Even now in India, ultrasound for the practice of anesthesia is not as common as it should be. So ultrasonography is what I will be focusing mostly on. The main reason is it has transformed the practice of anesthesia. This one imaging modality, so much so that we would like to call it the new stethoscope. So it helps us in real time see what is going on. So there is this terminology that we anesthetists commonly use, that is point of care ultrasound. Otherwise commonly called as focus. So bedside imaging will help us do a lot of these procedures. I'll just share a few. So Sona anatomy, that is what I want to highlight on. It is essential to know what the cross-sectional anatomy is and to correlate it with what we see on the ultrasound screen. So when we place in IGV cannula, this is what we generally see. And it is, if you know your cross-sectional anatomy, Sona anatomy is going to be easy. When we do arterial cannulations, this is what we generally see. We can see it in multiple axes. We can see it in real time. So the placement of the device is guaranteed. Echocardiography, everybody is quite familiar with. This is one of the earliest uses of ultrasound in clinical sciences. And with the availability of focus. So previously the ultrasound machines used to be big and bulky. They used to be kept either in the radiologist office or in the cardiologist chambers. But now it has become highly portable. There are devices that can connect to our mobile phones, and we anesthetists can easily and rapidly perform these procedures rather than sending the patient all the way to a cardiologist. Optic nerve diameter is something that is quite recent, maybe in the last decade or so. It's used to visualize the optic nerve and the optic nerve sheath, and we can assess the intracranial pressure from it. These are just a few examples. One of the things I commonly do with an ultrasound is airway ultrasound. So we directly visualize with a laryngoscope, we put the tube in, yes, but we don't know exactly how far it is from the carina. We usually need to do a chest X-ray, and once the patient is on table undergoing an anesthesia and surgical procedure, which may be hours long, it is not possible to get an X-ray till it is over. We don't know if we have put it in one bronchus or the other. So airway ultrasound generally helps us to, in real time, visualize what is the status, where is the tube. And sometimes when we do ENT surgeries, especially thyroid surgeries, the ENT surgeon is concerned, are the vocal cords moving or not? So right now, what we do is we use a video endoscope and other techniques. But with ultrasound, we can do it quite non-invasively. Lung ultrasound. So this is quite common nowadays in most of the major centers. We can easily detect pneumothorax, hydrothorax, pneumonia, a wide range of pathologies we can just come to know by placing the probe in the right position. And of course, what most anesthetists are familiar with is peripheral nerve blocks. Now, how does anatomy link in with anesthesia? One, it is in teaching the undergraduate students. So just as radio anatomy, that is just as X-rays and CT scans and MRIs are taught to first year MBBS students on how they should interpret it, Sona anatomy should be incorporated. Of course, a 3-year postgraduate course is required and the radio diagnosis is there to teach, but then the basics can be taught to students. There is a lot of scope for research in these avenues. How much of the medication is put? If we put it in this particular area, does it actually reach the target or is it reaching somewhere else? There are a lot of studies already ongoing and have been published in these references. So this, as you can see, is brachial plexus. You have to know the anatomy.
and then only the drug can be placed in the correct spot. Are we too close to any structure? Is the lung nearby? Are we going to puncture it or not? If we do, can we detect it with a lung ultrasound? One of the common blocks that I perform, especially in post-cesarean patients, is the transversus abdominal plane block, and this is exactly how it looks in the ultrasound image. And we just need to deposit the drug over here. Yes, can this be be performed under landmark guidance? Definitely, it can be, but we are never 100% sure till the effect comes, or if the effect is not there, we will say the block has failed. So we can, with ultrasound, we can see exactly where our needle tip is and is the drug delivered to the target site or not. This is the sonoanatomy of the femoral nerve, which we do commonly, and interventional pain procedures. So we can do a number of procedures, celiac plexus blocks, we can do superior hypogastric plexus blocks. Of course, all the blocks that we do in regional anesthesia can be extrapolated to interventional pain medicine. Gastric ultrasound. So with the increase in the emergency cases that come to hospitals nowadays, and for anesthesia, it is absolutely essential to know whether the patient is NPO or not. Because once we intubate them, the patient is going to lose all airway reflexes, and there's a very high chance they would aspirate. And most of the time, the patient or the bystander is not in a position to tell us the exact nil per oral status of the patient. Gastric ultrasounds are a very good way to determine if there is any chance of what is the risk of aspiration in that particular patient. So, coming to my take-home message, anatomy should not be just considered a non-clinical subject. It is very much relevant, and we should move, the subject should move from non-clinical or preclinical and become a clinical subject, a clinical anatomy. And this can be achieved by collaborations with the clinical branches through teaching program, research, and one good way of doing that is to incorporate imaging modalities or infrastructure into the department so that sonoanatomy and radioanatomy or endoscopic anatomy can be included. So ultrasound is the new stethoscope, and this, I feel, is the way forward. In fact, in many anatomy departments in the country, including CMC Vellore, they are using incorporating all these modalities to work with the clinical departments and to enhance their teaching for the undergraduate sciences. Thank you, and if there's any doubts, I'm open for this. Some kind of procedure. The exact rates, I don't have it, but most of the studies have shown that with ultrasound guidance, we can precisely target our blocks. For example, when we're doing landmark guided block for superior or cervical plexus, we can only do superficial cervical plexus blocks. But with ultrasound guidance, we can go deeper. We can do an intermediate cervical plexus block that is below the sternocleidomastoid. And you can go even further to and do the motor nerves can be blocked if you go through the missing fascia in the neck. So ultrasound, it precisely allows you in landmark guidance, only the entry point can be guaranteed. The depth is not always guaranteed. Yes, with skill, I know clinicians who perform all these blocks under landmark guidance with very good what would you say outcome. But that requires years of expertise, whereas ultrasound does not require as many years of expertise. to achieve the end target. That is, the patient should have a successful procedure.
For example, your abdominal ultrasound, I'm very clear at this. We go for the ultrasonography candidate. Aspiration. What are the actually limitations there?
So
As far as your ultrasonography.
I don't perform these procedures. That is what a gastroenterologist would do. I am an anesthesiologist, so I do anesthesia-related procedures. So this particular procedure doesn't come under my area of expertise.
Just because we're talking about ultrasound,
Yes.
graphic, I mean, direct, you already perform for the anesthesia.
I am an anesthetist and I do anesthesia-related procedures with imaging modalities, including ultrasound and CR, and of course video endoscopy.
Nice.
Thank you, Dr. Joseph, for the excellent talk. So I would like to request Dr. Anatomical to kindly felicitate Dr. Joseph. I would also like to request Dr. Anjanelu to kindly felicitate the chairpersons for this session, Dr. S.K. Chauhan.
ये सामने वाली आपको इतना बढ़िया पोस्टर लगाया हुआ तो दिखना चाहिए।
And Dr. So we have one more session that's coming up. So before that, we would like to break for 10 minutes. The tea has been arranged outside. So please join us after 10 minutes. It's in 10 minutes. The chairperson for the next session is Dr.